Before we start with our presentations, we're going to play a short video that just came online just a few days ago on the Stanford Healthcare website. This is a patient from the Stroke Center who illustrates what we're going to be talking about, which is the idea that we can extend the stopwatch for stroke much, much longer than we had originally been taught in medical school that we would be able to. So we'll start with the video.
When I woke up that morning with the effects of a stroke, it wasn't how I planned to start my day. When I tried to communicate with my husband, I quickly realized something was horribly wrong.
The doctor in the emergency room basically gave us the diagnosis, and they'd already done a scan and found the blockage. Basically said, you're past the window of any kind of treatment, that we just have to make her comfortable and see how she does throughout the day to make her stable. But the very next breath, he goes, well, Stanford has a study going on of expanding that window. Are you interested?
So the way that we used to take care of patients with ischemic stroke is it was very, very time sensitive. We were on the clock.
Patients who wake up with a stroke are not a candidate for treatment, and patients who have a stroke far away are not a candidate. But our Stanford study using imaging software changed the stroke treatment window from 6 to 24 hours. We're going to double the number of patients that we could treat under a 6-hour treatment guideline.
It was either that or do nothing. So, and knowing her, sorry.
Good. It's over.
It was the only thing to do. It was the only thing. So.
Stanford Transfer Center, this is Taylor.
That morning we got the alert coming in from Salinas Hospital. They have a patient, they were sending her to us because we have capabilities that they didn't have in Salinas to take care of that. Our life flight team brought her in, landed on the helipad and brought her down to MRI. She was in pretty tough shape. She was not able to speak that well. She was not moving her left side. Luckily, we were enrolled in a study that Dr. Albers was leading. We were able to enroll Cynthia in that clinical trial and offer her a treatment or a therapy that wouldn't have been available at other centers. Had we not been able to treat Cynthia and take her to the cath lab and retrieve that clot, she probably would have gone to the intensive care unit for a week or so, or maybe more, spent a couple weeks in the hospital. Most likely, she would have been pretty disabled for the rest of her life.
I am here today as a daughter, a mother, a wife, a sister because of Stanford and because of the phenomenal care I received. I'm so thankful to be a part of this trial. What saved my life is now the standard of care, and we've changed the guidelines for strokes. That means everybody after me has a chance. They're just fantastic doctors. They're very patient with our family. There's a lot of us to deal with. They all work together as a very cohesive team. They always took the time to explain everything they were doing, which is good because we had lots of questions.
They took the time and treated you like you were the only patient that they had. We felt like part of the team. I'm very, very grateful for the care that we've received here and continue to receive here.
We were prepared to do one thing that day, and we woke up and we had a totally different experience. I tell my friends to hug and kiss your loved ones every night.
Stanford saved my life. It's as simple as that.
Tell you a little bit about how we got to the point of being able to offer this treatment and where the future of stroke should be going. So the Stroke Center at Stanford was established a long time ago. It has been over 25 years since we brought a group of physicians together to try to understand stroke, to be able to diagnose it more accurately and offer new treatment options. And we've been very fortunate that over the years we've been able to have a number of major advances in stroke. It was completely untreatable disease when we started this group. And our biggest advancement was just what you heard about. And that's just a few months ago. In January, we were able to present the results of the study that the patient was enrolled in. So we'll start off with the basics here. What is a stroke? It's not as simple as you might think. It's hard to come up with a real quick and easy definition for what it is, because a stroke is really many different things. It's the injury that occurs to the brain when there's a sudden disruption in the blood flow. And that sudden disruption in blood flow from the brain can happen for two basic reasons. One is there's a blood vessel that ruptures open, and then you have bleeding in or around the brain. That's a very nasty type of stroke. But the more common type of stroke is a blood vessel leading to the brain gets blocked with a blood clot inside of the vessel. And that's the type of stroke that you just heard about in the video. That's the most common. That's about 85% of strokes. So we'll focus on that one, but we'll tell you briefly about the types where you have a ruptured blood vessel. Here's a ruptured blood vessel in the center of the brain. This white ball is blood on a CT scan, and you can see that these can be very devastating strokes. This patient obviously didn't make it. What do you think would be the most common cause of a brain hemorrhage like this? High blood pressure, absolutely. High blood pressure on the small blood vessels deep in the brain can cause them to rupture and bleed. So controlling blood pressure can make a big difference. Here's a blood vessel that is on the surface of the brain, at the base of the brain, that ruptures and spills blood all over the covering surface of the brain, which we call a subarachnoid hemorrhage. What do you think would cause this type of bleed? An aneurysm. The aneurysms, they are in the blood vessels at the base of the brain, right underneath the brain, and when they bleed into the spinal fluid space that surrounds the brain. These are also very devastating. But fortunately, they're less common. But the most common type of stroke is what overall is going to cause the most disability, and that's when you have a blood clot that blocks the blood vessel on that's traveling up to the brain, such as in the neck or in the brain itself. And there's two basic causes for these. One is a problem with the heart, such as atrial fibrillation, where you form a clot inside the heart, and that breaks loose and goes up into the brain. The other is hardening of the arteries, or atherosclerosis, the same process that can give you a heart attack by blocking up the blood vessels in your heart can give you a stroke by blocking up the blood vessels in your neck or the blood vessels in the brain. So that's the most common cause of stroke, and that's what we put most of our efforts into trying to figure out how to treat. We would rather not treat it because we'd rather you prevent it from happening. And there are many risk factors for this type of blood clot-related stroke, which are modifiable. And you probably already know this list because it's a list that's almost identical to the risk factors that occur for heart attack, right? So people who have high blood pressure, heart disease, atrial fibrillation, high cholesterol, diabetes, these are the same diseases that cause blockages in blood vessels all over the body, the legs, the heart, the brain. And you can see that most of these things are treatable. If you look at the behaviors, cigarette smoking, alcohol abuse, and physical inactivity, these are things that you can have a lot of control over. And blood pressure, of course, is the silent killer. People don't realize they have high blood pressure, or they realize it, but it doesn't bother them, so they don't treat it. And if you treat the blood pressure, you can substantially reduce the risk of stroke. You can see by 30 to 40% by getting blood pressure under control. If you stop smoking, even if you've been smoking for a long time, within a year of stopping, your stroke risk is cut by 50%, which is pretty remarkable. And after 5 years off smoking, the attributable risk from the smoking for stroke has gone away. So should be good motivation for people to stop. And then if your cholesterol is high, these newer statin medicines reduce your stroke risk by about 20%. Then there's simple medications like aspirin that can make the blood less sticky. The clot that causes a stroke is called a thrombus, and it's comprised of blood cells and sticky elements in the blood called platelets that form this clot. So taking a medicine like aspirin, which makes the blood a little bit less sticky, makes those platelets less likely to form these clumps that lead to a stroke, can reduce the risk of stroke. What about surgery? If you've got a buildup of this atherosclerotic plaque, which is full of cholesterol, you can remove it if it's in the right location. Oftentimes, particularly in Caucasians, it builds up in the neck, in the carotid artery, right below the angle of the jaw. It's right underneath the skin. So the surgeon can come in, do an incision, pull that plaque out of the blood vessel, and then you can take a look and see what it looks like. Not very attractive. You can see years of Haagen-Dazs and peanut butter and potato chips. That's the yellow. And what do you think the red is? That's the clot. That is the blood clot, right? And it's ultimately the clot that is usually causing the problem. So why did the clot form? Well, this plaque is very sticky. It's a very sticky surface. It can cause the blood clot. The blood clot can block off the vessel there, or more commonly, it breaks loose and it heads up into the brain. And what you're going to hear about is the new way where we remove these clots from the brain from Dr. Heit in a few minutes. So here's a patient who's having a stroke. So the blood clot, which we call the thrombus, is blocking off a blood vessel to the brain. So the symptoms are going to depend on what part of the brain is now starved of blood flow. If it's on the left side, you could be paralyzed on the right side of your body and not be able to speak. If this is on the right side of your brain, you could have difficulty with the left side of your body, and you may not recognize that you're having a stroke. So stroke can cause different symptoms depending on what part of the brain is affected, and oftentimes the person having a stroke is either not aware of it or is unable to speak and communicate about it. That's why it's important for everybody to know about stroke risk factors, so you can be the one to call 911 if you see somebody who's having a stroke. Then we want to get rid of this clot, right? We want this clot out of there. So there's a couple of different approaches. The first approved treatment for stroke, way back in 1996, was tissue plasminogen activator, or TPA. So what TPA does is it dissolves the clot, or at least it tries to do that. So a clot is formed by a lot of ropes. See these little ropes? These are called fibrin strands, and they trap the platelets and the red blood cells into this clot. But inside every clot is an antidote to dissolve it, and that antidote is called plasminogen. And TPA stands for tissue plasminogen activator, means that it's going to activate this plasminogen and turn this into a little Pac-Man that's going to go around and chew up those ropes that are causing the clot to stay together. So that is a way that you can dissolve a clot, but it's very restricted. It can only be given if the patient arrives, according to the FDA, within 3 hours of when the stroke began. But lots of people wake up with a stroke, and very few people can get in that quickly. So it means that we don't treat a lot of people with this just because we're not in that very tight window most of the time. The other thing is if the clot is small, this is very effective, but if the clot is really big, it's not effective. So that's a step one, and we've had this for 20 years, but we needed to move on to additional strategies to help stroke patients. So this was an advertisement which actually was in the Bay Area editions of Time magazine way back in 1992. Okay, so time is the key thing because we needed time to treat stroke patients. And at that point, there was no approved treatment. And we had the idea that we might have 6 hours. We had some preliminary thoughts and data to suggest that really 6 hours could be our time window for helping stroke patients. And we wanted to try to turn back time. So how did we go about figuring out how to help patients at extended time windows? Well, it started with one of our radiology faculty members at Stanford named Mike Mosley. He was looking at new imaging sequences, and he discovered one called diffusion-weighted imaging, which allowed you to see the stroke in real time. Before that, all we had were CT scans, and the stroke wouldn't show up on the CT scan typically for 6 or 8 hours. You couldn't see it very clearly, which means when you're trying to make a treatment decision, you have a normal CT scan, and you don't know that the patient is really having a stroke, where it is, how much tissue is irreversibly injured, and how much tissue is salvageable. But with this MRI technique, we could see the stroke in real time. So we started scanning everybody in the mid-1990s with a stroke with this new MRI sequence. It's called diffusion-weighted imaging. And what we expected to see is what's shown here. This is a patient who comes in about 2.5 hours, 3 hours after the stroke, and this pink area shows the tissue that's dead. Patient couldn't speak, they're paralyzed on the right side of the body, and you take a picture and everything's dead. And that's what I was taught in medical school. We're not going to be able to treat stroke because the time between when it starts and when everything is dead is typically only a few hours, right? But as we started scanning patients, we found this was not the typical patient. This was actually the exception to the rule. Only about 20% of patients look like this. Most patients look like this. This is a patient who looked identical in the emergency room. Can't speak, can't understand what others are saying, paralyzed on the right side of the body, can't feel things on the right side of the body. But this patient, it took 11 hours from when those symptoms began to when they got into Stanford. And look at how much damage is there. A tiny amount of damage. But if you take this picture a few days later, you'll see what we saw in patient number 1. So we started to get the idea that every single stroke patient is different. And it's not going to make any sense to treat people by an arbitrary time window. 3 hours for one patient can be completely different than 3 hours for another patient. So we knew that imaging was going to be the key to selecting patients for appropriate stroke therapies. So we had this diffusion imaging that we could do on MRI. But most places can't do an MRI scan when you come in because the ERs don't have MRI scans. They have CT scans. And I already told you that the CT doesn't show the stroke right away. So we worked on a technique called CT perfusion that allowed you to see the dead tissue on a CT scan, the same pink spot. And then we needed a technique to show how big is the stroke going to be if we don't do anything about it. And that's the green area. That's going to give us an idea from this scan how much tissue has low enough blood flow that it's likely to die. But the difference between the green and the pink, that tells you how much is salvageable. The pink is dead, the green is going to die. So all you have to do is subtract them and we can see what's the mismatch, how much salvageable tissue is present. So when we first started doing this, it took us about 40 minutes to generate these maps. And that was not going to fly, right? So we had to hire a software engineer to develop a program to generate these maps in 2 minutes. And that's a program called Rapid. So that was developed at Stanford. It was then sold by Stanford to the industry, and it is currently in over 400 hospitals in the United States to allow hospitals to identify very quickly who has salvageable tissue. So identifying salvageable tissue is one thing. Getting the clot out is another thing. I already told you if it's a big clot, then the clot-busting agent TPA doesn't work very well. So people figured you've got to pull it out. You've got to use some physical device. So can you see this device? Okay, this was developed by a French neuroradiologist. And you can imagine he was sitting there popping the cork on his Bordeaux one night saying, hey, a blood clot in the brain is not a lot different than a cork in my bottle of wine. So he developed this. And it worked okay, but not terrific. So then another company developed tiny little vacuum cleaners to go up through blood vessels in the brain to suck the clot out. They worked okay, but not terrific. But it wasn't until about 7 or 8 years ago that these devices were developed. These are called stent retrievers. And these look like what a cardiologist might put in your blocked up coronary artery in your heart, but instead of opening it up and leaving it there, it's being used here to capture the blood clot and then pull it out. And Jeremy is an expert in doing this procedure, and he's going to show you a lot of pictures on how he does this. So now we had something effective, and we had the imaging to give us an idea which patients are most likely to benefit. So there were 5 studies done across the world. All of them were published in the New England Journal in 2015. So it was a huge year for stroke 3 years ago in 2015. These were studies that treated patients within 6 hours of symptom onset using the stent retrievers, patients who were coming in with big strokes. They were all positive, but the studies that were the most positive were the 2 trials that used the Stanford Rapid software. So we were really excited about that, but even more excited that we could treat stroke within 6 hours, because remember back in our Time magazine ad, we had predicted that you could treat stroke within 6 hours. So, and people had been quite skeptical. In fact, we took a lot of heat for that advertisement, saying you really don't have proof of this, but finally the proof came through. It just took 20 years to do so. So this was great news, but not great news for every stroke patient, because most stroke patients can't get to a specialty center like Stanford that can pull these clots out within 6 hours. Okay? What if you have your stroke in Modesto? What if you wake up with your stroke? 1/3 of the time people wake up with a stroke, and then you have to date it from when you went to bed. That's beyond 6 hours. So what we really wanted to do was to shatter the stroke stopwatch and say it's not about time, it's about your brain and how your brain is reacting to this stroke. Now, people were very skeptical, and it was hard to get grants funded because they said, well, this is not going to work because we know brain tissue dies quickly. And this is a typical study where people would look at what's the rate of good outcome. So this here is showing you on the y-axis the rate of good outcome based on the time from when the stroke started to when you got the blood vessel open. And you can see that this is a sloping graph that is very discouraging. And that's at 8 hours. And if you extrapolate this out to 16 hours, the prediction would be, well, nobody's going to do well when you pull out the clot at 16 hours. So we didn't believe that because our imaging software had said we see plenty of patients where it looks like you can pull out the clot at 16 hours and they can do well. So we initiated 2 different trials, one called Dawn, which was sponsored by a company that makes one of these stent retriever devices, and then one called Diffuse 3 that you guys paid for. So thank you very much. This was tax dollars through the NIH paying for our Diffuse 3 studies. We used the software we developed called Rapid to select all of the patients for both of these studies to try to see could we help patients beyond the traditional time windows. So this is the first one called Dawn. And this one, we were pretty conservative here. We're basically looking at people who only had a small pink lesion, couldn't have very much damage because people, again, were skeptical. And in this trial, we were going out to 24 hours. So if the software said they have a small amount of irreversibly injured tissue, half of the patients would get the thrombectomy procedure where you pull out the thrombus, half would get standard medical care, and then we look to see how the patients did at 3 months. And the results were quite amazing. In fact, they were so amazing when they were released a year ago that people didn't believe it because the good outcome rates were more than people had ever seen before. Incredible increase, 35% absolute increase in good outcome. This is a scale where good outcome is shown here, bad outcome is shown here, and you can see there's a tremendous increase in good outcome and a tremendous decrease in bad outcome. Okay. So we needed to stop and take a look at the results in our Diffuse 3 study when we heard that the first study was positive. The Diffuse 3 study was taking a much broader approach. Rather than you have to have a very tiny amount of dead brain to get into the study, we said you can have a fair amount of irreversibly injured brain as long as there's still a lot to save. So again, it's patients who have a clot in a major blood vessel who can be treated up to 16 hours. And then we use the software to find the right patients. So the pink area here, we would allow to be as big as 70 milliliters. So it could be a fair amount of injury as long as the green area was twice as big, meaning that there's a lot to save. So again, half the patients were randomized to have the clot pulled out, half the patients had standard medical therapy. And what you can see on the standard medical therapy is good outcome is very uncommon for somebody with a big clot in their brain. And the bad outcomes, this is nursing home totally disabled and this is dead, the bad outcomes are pretty high. Here's how we did with the treatment, and you just saw a patient who was in this treatment group. You had a tripling of the good outcome rates. You can see that here. Good outcome rates were tripled, and never before seen in a stroke trial, serious disability, the type that puts you in a nursing home for the rest of your life or death, was cut in half. So this was amazing. We were so happy to see these type of benefits. So on the day that we presented these results at the International Stroke Conference in January, 3 hours later, the guidelines, the international guidelines for stroke treatment were changed based on these 2 trials. And now we have a 24-hour window, but you have to use the software to identify patients who can benefit. So we can conclude that after 20 years of work, the stroke stopwatch has been shattered. So now we're going to turn it over to Jeremy, who's going to show you exactly how this procedure is done, how we choose the patients, and how we can make patients better.
All right. So thanks again for coming and spending your Saturday morning with us. I'm Jeremy Heit. I'm one of the neurointerventional radiologists at Stanford, and I work very closely with Greg. So I want to talk about how we do these procedures, because it's pretty neat, and I have a really great job, and it's always a pleasure to get to talk about it. But really, the fundamental thing that you just heard is precision imaging is really key part of these procedures. Making sure you pick the right patient to help them is important. Here's a patient with a stroke. We see a little bit of injury in the deep part of the brain with the yellow arrow. And then we have an angiogram that's showing why the patient's having a stroke. And there's a blockage of the first part of the middle cerebral artery. That's shown with this arrow. So what happens to the brain? Well, Greg has nicely introduced this. You cut off blood flow. Some part of the brain can't tolerate that. It dies. But fortunately, most patients have a larger part of brain surrounding that that's viable and salvageable. And we now have these imaging tools to identify these areas. And we spend a lot of effort, and Greg's had a really storied career actually, in getting these type of studies to be able to sort out dead brain from salvageable brain. So we have a patient who comes into Stanford, and they look something like this. They've got a major artery blocked, there's some dead tissue, there's some reversible tissue. If we can open up that blocked artery, then all the blue tissue goes back to normal. We save the patient from having a bigger stroke. And that's called reperfusion. It's restoring blood flow to the brain, and that's the goal. But if we're not successful and that artery stays blocked, the stroke gets bigger. And a patient with a bigger stroke is going to have a worse outcome and may even die. So the goal that we're trying to do is to open up that blood vessel in the right patient and minimize the size of the patient's injury to the brain so that they can have a good outcome. So who's a good candidate for a procedure to pull a blood clot out of your brain? Well, you really need three things. You need a relatively small stroke, so a little tiny core infarction. You need a little bit more tissue, and it should be bigger than that, that's at risk of dying if you don't open up the blood vessel. And then you need a large vessel occlusion, meaning you need a blockage in an artery that you can get to from inside a blood vessel. And if you have those three things, then you're a good candidate for treatment. So how do we do this? This happens to me a lot. My phone goes off. This one was 12:17 a.m. and the transfer center calls. And there's a patient, usually at an outside hospital, with a stroke, and they want to know if it's someone that we can help. So as soon as that phone call comes in, we actually launch a helicopter. We have a wonderful life flight team, and they go en route often before we're even on the phone with the outside hospital. They're on the way to the hospital to pick up the patient. We hear the story. If the patient's someone we think we can help, we load them on the helicopter. They come to Stanford. They go directly to an MRI or a CT scan to evaluate the status of the brain. And if we've made a decision that it's someone we can help, we go straight up to the endovascular suite. And then that's where my job starts. So this is a picture. There's a tiny little needle and a wire in the common femoral artery in the leg. So by just using a little needle, I can get access to the inside of an artery. And once you have access to the inside of an artery in the leg, kind of like driving on the highway, you can actually drive all the way up the aorta, up through the neck, and all the way up to the arteries in the brain, right to where the blood clot is. And you can actually do this quite quickly if you know your anatomy and you know how to get there. And then once we get there, we can really do a couple of things to try to get the blood clot out. We could give a medicine to try to break the blood clot and make it go away. That's an older technique that we don't do that often, but it still has its use. We can use these vacuum cleaner catheters to try to suck the blood clot out. Or we can use these stent devices that Greg was showing you and try to grab the clot and pull it out of the brain. And these are the tools that we have, but the idea is to physically interact with the clot and get rid of it. All right, so exactly how do we do this? Well, here's a patient I took care of. A 73-year-old man, came in with paralysis on the left side. These images are backwards because radiologists like to confuse you, okay? So that means that this is actually the right side of the brain. Right? So there's a little bit of injury that's very subtle on CT scan to the deep structures of the brain on the right. We can see this perfusion imaging showing us delayed blood flow to a large part of the brain on the right. And we have a CT angiogram here that shows blockage of the first part of the middle cerebral artery. So we've got a small stroke, we got tissue at risk, we got a vessel we can get to. We look at our rapid software, there's a clear mismatch in the amount of injury to the amount of potential injury in the brain. This is someone we can help. So the patient goes right upstairs. This is a picture that we've taken by putting one of these catheters from inside the arteries, injecting a contrast dye that shows up as black. And what you see is right there. Where the contrast stops, that's where the blockage is. And this is right where we thought it would be in the first part of the middle cerebral artery. I'm now going to show you a series of videos that kind of is exactly how we take these blood clots out. This is a patient who's awake. Most of our patients are awake. They're just sedated by the anesthesiologist. And the first thing we need to do is get across the clot. So here you're seeing a small wire being navigated through the artery. Now it's being pushed past the clot. Once that wire is out, we can ride a very small catheter, a microcatheter. It's only 1 millimeter or 2 in diameter, over the wire to position it past where the clot is. We take that wire out, and now we need to put one of these stent devices out. And the stent device is being pushed through. Here's the tip of the microcatheter here. We put the stent so that it's positioned across where the blockage is. And then the next thing we do is kind of like unsheathing a sword. You take the microcatheter off, which exposes the stent and lets it open in the artery in the brain. And that's being done here. It's the tip of the stent. There's the guiding wire. Now the stent is exposed. It's pinning the blood clot against the stent on the inside of the artery. We then put up a bigger catheter to try to suck and pull at the same time. And here we are pulling the blood clot out of the artery in the brain. You can see it's moving back. Patient's having a little discomfort, which we give medication to keep them more comfortable. And pop, we pull it out. Okay, we'll let it go one more time. Pulling, 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 and out it goes. We look on the back table, and sure enough, there's the blood clot that was stuck in this patient's brain. So this is where we started, and this is where we ended up. So now the blood vessel is completely open. This took 13 minutes from when we put the needle into the artery in the leg to this picture. So you can do this remarkably fast. Here's how we started. Again, we had a little bit of injury in the brain. On the follow-up MRI, it didn't get any bigger, so we kept that stroke nice and small. The blood flow deficit goes back to normal, so there's no more tissue at risk. And our angiogram now shows completely open blood vessels in the brain. This patient walked out of the hospital 3 days later with a stroke scale of 0, absolutely no symptoms whatsoever. And that's what we're trying to do. So that's how we do it. Wake-up strokes. Dr. Albers told you around a third of strokes, you wake up with your symptoms. You don't know if that started 10 minutes before you woke up or 10 minutes after you went to bed. So when you're on a clock, that's a problem because you don't know if you're a candidate for treatment. But now because of these studies, we know we can at least think about treating you if you fit the right profile. Here's a young gentleman, not much older than me, who woke up with left-sided paralysis. Came into Stanford ED. Again, extremely subtle injury to the deep part of the brain and very, very minimal. We have a blood flow study that shows a lot of tissue at risk of dying. And we have a CT angiogram that shows the entire internal carotid artery on the right is gone. So that's a big problem. This is someone we can help. We look at our rapid software. The injury is so small we don't even pick it up. And we have, again, a lot of tissue at risk of dying. Here we go. So this is, again, that first angiogram image. And the arrows are pointing to the area of blockage. So this whole region up here that's just gray, that's where the brain is. And there's absolutely no blood flow going up to that right side of the brain whatsoever. But fortunately, we're able to pull the blood clot out. And now we've opened up the internal carotid artery, and all of the arteries that fill the brain are filling nice and normally. We started like this, very minimal injury. You can barely even see it. This blood flow deficit on the perfusion image in the middle goes back to normal, and the vessels remain completely open. And this patient went home actually the day before Christmas with no symptoms whatsoever. All right, what about these late time window patients? So this is a little bit different. Someone sees your symptoms start, you're in the Central Valley, it takes a long time to get to care, it takes a long time to get to a hospital like this. That's also another patient that we can help if they fit the right imaging criteria. So this is another patient I took care of. She's an 86-year-old woman, and she came in with left-sided paralysis. And by the time we took these pictures, she was 8.5 hours into her symptoms. So you heard the old 3-hour clock, which we extended to 6, but until this year, this would still be someone that we wouldn't be able to really offer anything to under official guidelines. But now we know better. So what do we see here? Same kind of thing, really subtle injury, you can barely see it. The perfusion blood flow study shows a lot of delayed blood flow to the right side of the brain. And again, we have blockage of that first part of the middle cerebral artery. Excuse me, that was internal carotid artery. Here's the rapid map. So again, we don't see anything for the core dead tissue, and we have a lot of tissue at risk of dying if we're not successful. This is someone who can help. We go up to the endovascular suite. Here's the picture. And again, nothing going past that area of blockage. So the whole brain is not filling. Here's a picture. You can see the type of anatomy that sometimes you have to deal with. It's like Lombard Street. But you can even get through all of that. And here's a stent device that's deployed across where the clot is. And we do the same maneuver I showed you before. We pull the blood clot out, and we're able to go from this to that and completely open up everything. And this, again, was about a 15-minute procedure in this patient. So extremely rapid way to restore blood flow to the brain. This is the initial pictures. I've put arrows on these couple of very subtle areas of injury. This is her follow-up head CT that shows the injury in the exact same place. It did not extend whatsoever. So we were again successful. We took what could have been a very large stroke if we hadn't done anything. We opened up the blood vessel, and the patient left the hospital with the same size of dead tissue that she came in with. So just to summarize everything that we've told you guys, this is a really exciting time to be involved in stroke. It's a very exciting time to be involved in the neurointerventional treatment of stroke. And it really is highly effective. These are really spectacular results. It's much more effective than even going for a cardiologist. If you have a blocked coronary artery and you do an angioplasty or you put a stent in, The data for that, you have to treat 17 patients to help one. And Greg told you for this procedure, you need to treat 2 patients to help one. So that's a huge, huge difference, and it's spectacularly effective. And it's a really, really monumental step forward in the care of patients with ischemic stroke. And I think we are happy to take some questions here.
We've got lots of questions here.
That's good.
We'll start up front.
Oh, here, sorry. Hold on one second, we have a microphone.
Oh, hang on, we got a microphone.
What about the other kind of strokes, the bleeding or those kind of strokes that you showed the brain with a significant amount of blood?
Yeah.
How do you treat those patients?
Great. So we showed 2 different types. One that's the subarachnoid hemorrhage that's caused by aneurysms. You want to tell them how you treat aneurysms?
Yeah, so aneurysms we can also treat, and there's 2 ways you can treat them: with surgery, where the surgeon goes and reconstructs the artery by putting a clip across where the aneurysm is. An aneurysm is like a little berry hanging off of an artery. And we're also able to treat those in a minimally invasive way by coming similar to what I showed you from inside the arteries and packing the aneurysm from the inside. And we do that very frequently.
And for the other type of hemorrhages, it's really better to prevent it from happening in the first place. And again, that's the high blood pressure. Because once you have that big ball of blood in the center of the brain, very, very difficult to treat. We're looking at some techniques where we can put a little straw into it and try to suck it out. Because we know when you go to surgery, when one of those deep hemorrhages, things don't go well. So you'd rather prevent those than treat them. Question?
Should everyone take aspirin as a preventative measure?
We'll repeat the question since it's probably going to be hard to get the mic everywhere. Question, should everybody take aspirin? And the answer is no, not everybody should take aspirin. There's always a risk to every benefit with a medication. So if taking aspirin every day for the rest of your life sometimes can irritate the stomach and increase the risk of bleeding. So you have to be somebody who's at risk for a heart attack or at risk for stroke to have the benefit exceed the risk. So you need to talk to your doctor. Okay, somebody's got the microphone. Yeah.
Yes, hi. I have had 2 TIAs, which they think are TIAs. I can't really prove it. And I was wondering if you could speak to that. What is it? Just if you could really explain what a TIA is and what, and how it leads to a full stroke.
Sure. So a TIA is a transient ischemic attack, which means that you've got the symptoms of a stroke. They come on quickly, but they disappear very quickly. And usually it's because your body dissolved the blood clot, right? So if it's really a TIA, you want to be seen right away to try to figure out, do you have blockages in your neck? Do you have a problem with your heart that could predispose to that? And then there's going to be medications, such as the ones that I talked about, the blood-thinning medicines like the aspirin and the cholesterol medicines. But some things mimic a TIA. It can be pretty tricky sometimes because somebody who might have a seizure or somebody who's got a migraine or a pinched nerve. So it's not always easy to tell for sure was it a TIA or not. You want to comment about imaging with TIAs?
Yeah, so we always, the imaging evaluation of a patient like yourself with a TIA is actually very important too, because you want to see if you've had any injury to the brain. And also we want to look for any areas in the neck where you may have narrowing in your blood vessels that need to be addressed. People are looking at imaging of the heart to make sure that it seems to be functioning normally. So there's a whole kind of treatment algorithm that should be gone through for someone with a TIA.
And the important part on your first TIA, you want to treat it like an emergency. Because after somebody's had a TIA, the risk of stroke is highest in the first hours to days. So you don't want to have a TIA and then see your general practitioner 2 weeks later, because that's the high-risk period for having a stroke after a TIA. All right, where's the wandering microphone? Who's got it? Okay.
So this has been extraordinary to see this. Can you do this multiple times on a patient maybe who has multiple strokes, assuming they fit the protocol?
So that's a good question. There are a small number of patients that we have taken care of here who are unfortunate enough to have a stroke on one side, while they're still in the hospital, throw a blood clot from the heart again to the other side or even back to the same side. And we have treated those patients in the same way because, again, we think the clock is stopped. We go off of what the imaging looks like. And as long as you're able to get the clot out in a timely manner, people will still do very, very well.
Okay. Where's the microphone?
There's one way in the back there.
In the back, okay.
looks like time is of the great essence in these things, and you have a very good procedure. But how many people, if there are two strokes or 3 strokes, and is Stanford the only place who can do this, or are there other hospitals in the Bay Area who can do this?
Yes, yes, there are. And when you started your comment and you said time is of essence, I wanted to pick up on that a little bit, because sometimes when I give this talk, people can misinterpret it and say, look, he's showing people benefiting at 16 hours. Maybe I don't need to rush in. And that's absolutely not the message, right? Time is still incredibly important. The point is everybody's time clock is different, but sooner is always better, right? So if you recognize a stroke in yourself or someone else, you want to call 911 and you want to come to the closest hospital, right? So the paramedics are going to take you to the closest hospital. And there's different types of stroke centers. Some are primary stroke centers, and usually your closest hospital, if you're living in the Bay Area, is typically going to be a primary stroke center, which means they can give the TPA, right? They can give the intravenous injection of TPA to start chewing that clot. But if it's a big clot, then you need to go to a comprehensive stroke center, one that can do what Jeremy does. And there are several of those in the Bay Area as well. So UCSF can do this procedure. We do it at Stanford. Kaiser Redwood City is the one Kaiser hospital in the area that does this procedure. And then there's a couple of places in San Jose who can also do the procedure. So it's the idea of getting you first to the closest hospital to figure out what's going on, because it may not be a stroke, it may be something else. But if it's a stroke and TPA is not going to be enough, which is the large artery strokes that Jeremy showed you, then you're going to typically go by helicopter or ambulance to a comprehensive center that can pull the clot out. What people are talking about now is trying to direct you sooner to that comprehensive center, right? And that's a controversial area. Are you going to bypass the closest hospital that could have started the TPA to go straight to Stanford? And we're not quite doing that yet. We're still trying to work out the best way to do it, because you don't always know when you're in the ambulance whether it's a stroke, and even if it looks like a stroke, is it one that needs this type of treatment? Okay.
My question is partly like the one that was just asked. For people not so lucky to live in the Bay Area, let's say people have to move to Florida, for example.
How horrible, yeah.
And you're not near, I know Miami has good, but how does someone determine what are good every kind of thing, stroke centers, hearts? Because I would imagine a hospital that's a good stroke center, probably a good center for many other things. But how can patients that are not exactly living in the boonies, but in areas without good hospitals, help themselves in advance, seniors, for example?
It's a good question, and I would just preface it by saying that with this big increase in potential people we can help, across the whole country, we're really trying to figure out the best way to be efficient. That's sort of what Greg was getting at. But yeah, you're right. If you don't live right next door to Stanford or another comprehensive stroke center, you don't have good shopping sometimes, and you don't have as quick access to a big medical center like this. That being said, there are systems of care all over the place that are trying to design a system where you come into whatever hospital and there's some mechanism to get you to an expert hospital. I would say that not every center is probably the same, even with a good designation, and that's the intangible part of it. Most of you in the room are probably very lucky that you're close to excellent medical centers like this, because it's not just one person. You've got 2 people from very different backgrounds here. Even though we take care of the same patient, our training is very different. This is a very multidisciplinary and complex field where you need experts in neurosurgery, neurology, radiology, physical therapy, nursing, rehabilitation. It goes on and on and on. And the more you can pool those expert resources in one place, in my opinion, those are the best centers. But it's very difficult for an individual patient to predict what's going to happen. Yeah. So you have to kind of rely on the medical system to help get you to the right place.
Yeah, this is a procedure that you don't want to be done at every single hospital, because the results are much better at the type of center that Jeremy just described, because it's not only getting you into the procedure, but it's how the patients are treated afterwards. Yesterday morning I was in Sweden for the European Stroke Conference, And one of the presentations on Thursday was, how are the results of this procedure in hospitals that just do a few of them a year versus hospitals that do them all the time? And I bet you can guess, yeah, what the results were. So that's why we like to funnel patients in, and we have a very active life flight to bring patients to Jeremy and his team who do this every day. Okay.
You listed a number of risk factors for stroke, and included was atrial fibrillation. You did not include PVCs, premature ventricular contractions.
Yeah.
Are they not connected at all, or?
They're not connected directly, but people who've had injury to the heart are going to be at increased risk for having PVCs and increased risk for atrial fibrillation. So atrial fibrillation is the most common cause of a stroke coming from the heart. And it's usually older individuals who've had heart disease, like heart attacks before, or years of high blood pressure on the heart, which can make the heart muscle thick. But the PVCs themselves don't form the clots inside the heart, but the atrial fibrillation does. So if you have atrial fibrillation, you have a couple of different options. There's some techniques to try to cure the atrial fibrillation that the cardiologists do, or there's medications, and we have new ones, which we call NOACs, which are fancier blood thinning medications that are quite safe, that prevent clots from forming in the hearts of patients who have atrial fibrillation. Up here.
I have a simple question. I wondered whether El Camino Hospital offers endovascular therapy.
I don't know. I know they are interested in offering it. I'm actually not sure what their staffing is right now.
Thank you.
We do get patients from El Camino, and it's a very quick transport from there. The microphone in the far back there.
Hi. How is it possible for you to have like a mini stroke, so to speak, and not even know it until later when you have a CT for something else and it shows up on that?
Yeah, because the brain has some silent areas, right? There are certain areas of the brain that are very critical for different functions. Like if you have a little stroke in your language areas, you're not going to miss that, right? Because you're going to have trouble making the words or understanding the words. You may say nonsense words. But there's other areas, often in the right side of the brain, which you may not notice anything. But as you start to have more and more of those, it's going to take a toll on your cognitive function, your ability to think and remember things. So it's not unusual. Oftentimes the patients with atrial fibrillation, like we talked about, they can throw tiny little clots into a relatively silent brain area and they don't notice it. Or maybe the symptoms were so subtle that they didn't notice it. But obviously that's going to put you at risk for another stroke. So when we see those silent brain injury areas, that means we want to look carefully at the blood vessels, at the heart, and see that we can do everything to reduce your risk factor for having a symptomatic stroke.
Can I follow on that question?
Sure.
So what should we do in that case? We had a stroke, let's say I have a stroke, I didn't know 3 times in the last 2 years of the vision lost. And so last time I had a scan, what I call ultrasound on the neck. So I think that's okay, but what should I do now? I mean, see a cardiologist or see you, or how does that work?
You want to take that?
So just for the record, we can't actually give out personalized medical advice in this setting. But what I would say, it's important for you to see your physician to discuss what your risk factors related to these TIAs, or if they were strokes, small strokes were, so that you can reduce the risk of it happening again.
Okay.
Up front.
Genetic issues like AVMs that are seen, you didn't know you had it, but seen with other CAT scans or MRIs. How do you deal with that?
So this is the questions about AVMs, which are arteriovenous malformations. And these are a little bit different lesions. So these are lesions where the arteries and the veins in the brain are hooked up abnormally. And the blood, the high pressure from the artery gets transmitted to the veins, which they're not designed to handle. So it depends on how it's found. And actually, these are troubling lesions to know what to do with in some sense. Most of these are actually found when they bleed. And that's not a good thing. And in those cases, I don't think anyone would argue with not treating it, and we would recommend treating them. But more and more as we do scans for other things, we find them kind of incidentally. Oh, you had a headache, or maybe you fell and kind of bonked your head, and we look and we see it. well, then it's a little bit trickier to know what to do with, and that's kind of controversial in the field. It's a little bit up to every patient. It depends on how old you are, what the AVM looks like, where it's located, but there is a solid risk of somewhere between 2 to 4% a year that it could bleed, and it requires a conversation with multiple people that take care of them. And usually it's with neurosurgeons, neurologists, and people like me, neurointerventional radiologists. So.
Okay, Mike?
What percentage of incoming stroke patients satisfy the criteria for you to move forward with your treatments?
Yeah, that's a great question. How often do we have this favorable pattern? So many patients will have little tiny strokes, right, which we call lacunar strokes, and they are not going to be a candidate for this type of procedure because it's a tiny little blood vessel that's being blocked off. And Jeremy can't get his tools into these tiny little blood vessels. But the good news about those is usually the prognosis is very good. So what we're talking about is the bad type of stroke, when a large blood vessel, one of the main blood vessels like the middle cerebral artery or the internal carotid artery is blocked. And those are the most common causes of the really severe strokes, the type of stroke that puts you in a nursing home. So when we see those patients who have those major blood vessels blocked and that's causing substantial symptoms, 50% of the time, they met the criteria to get into the Diffuse 3 study. So 50% of the time, we had to say, sorry, the stroke has grown too big, we can't help you. But half of the time, they qualified. So it's a lot of patients. And at Stanford, since the results of Diffuse 3 came out, our volume has tripled. It's actually tripled. We predicted it would double, but at least over the short run, we've had triple volume of getting these patients. And it's a lot of people who are coming in from Modesto and Salinas and Stockton and Monterey and Santa Cruz, people who would normally not make it in the time window, so they never sent them before. But now that the word is out, we're getting a lot more of these patients. So we're really excited. We want to do something more for the people who don't make the criteria, and we're looking at other options for them as well. Let's see, the back microphone. We'll go front to back here. Yeah, go ahead.
Well, my original question was going to be about lacunar strokes, which you just talked about. Is there nothing to be done for repeated lacunar strokes?
So with a lacunar stroke, you have to try to figure out what the cause is. And usually, but not always, it's hypertension, diabetes, cholesterol, smoking. It's something in that group. But sometimes genetics play a role in those tiny strokes as well. There's not a whole lot we can do about the genetics, right? We can't change who your parents are. But if there's risk factors that are treatable, like the ones I had on my slide, obviously we're going to be very aggressive in trying to treat them. We like to see the LDL cholesterol go really low for people who've had repeated lacunar strokes. We like to make sure you're on one of those antiplatelet agents like the aspirin or Plavix. And then we want to make sure that patients are exercising, that their diabetes is under good control. So those are the type of things that we focus on for lacunar stroke prevention.
Yeah, are vein occlusions inside the eyeball, they related to stroke at all?
So typically not. Those can usually be related to, some people just form blood clots a little more easily than others, called hypercoagulable. They could be from that reason. There could be a blockage in a bigger vein further back that's sort of letting the veins not flow as readily, and anytime blood's not flowing, it can clot. There's some just abnormalities the veins are too big, and when they're too big, the blood kind of swirls in them instead of moving forward in a straight way, and then you can form clotting there. It's more the arteries that you'd be worried about causing a major injury. Vein problems do exist, and usually more in the brain, but they're fortunately not as common. We see them in not the best situations, often in pregnancy, for example, or people who are very dehydrated can clot off the veins in the brain, and that can cause you to have bleeding in the brain.
So we've got 2 minutes left, so if we're efficient, that could be two more questions.
Okay. If you have one TIA, does this predispose you to have more TIAs? First question. Second question, if your parents have had numerous ones and passed away, does genetics play a part in that also?
Genetics plays a role, absolutely. So if you have a family history of people having strokes, particularly at a young age, that's of concern, and it's reason to talk to your doctor to make sure that we're clear on what your risk factor profile is. The beginning of your question was, if you've had one TIA, does that predispose you to another one? It predisposes you not only to another TIA, but more concerning is to a stroke. right? And as I said earlier, it's often that once the TIA occurs, the stroke can happen within the next 12 to 24 to 48 hours. And that's why we want people to come in right away after TIA. First of all, because TIAs are tricky to diagnose. Sometimes the imaging can give us the answer and that we can know what's going on with the imaging. But if the imaging is completely normal, we have to think about other things that could be mimicking a TIA and might want to be treated differently. So again, it's better to come in right away if you think you're having a TIA event. Okay, last. Good. You have a follow-up?
Yeah.
Then that won't count as the second question.
Would it be important to know if that TIA, if there's a history of it, how does that follow into?
So if it's a history of it in the same type of TIA having over and over again, it's going to tell you, I'm very suspicious there's a blocked blood vessel, right? Because if the problem is coming from the heart, it could cause a TIA here one day and a TIA here the next. But if it's the same area of the brain that's flaring up over and over again, then we say, well, I bet there is a blockage in that carotid artery. So we're going to have to look very closely at the whole course of the vessel and see if it's tightly blocked. Then we're going to want to get that opened up. Either Jeremy or his colleagues can put a stent in and open it up, or a surgeon may be able to open it up. Okay, last question. It's got to be a good one. It's the last question.
Okay.
Okay, front row.
What's it? I didn't understand this before, but there's a difference between a stroke and a heart attack. So
okay.
What are the symptoms? How are they different?
So the similarity between the two is that in both cases you're talking about an artery being blocked that's going to some tissue. So when you block an artery going to the heart, you know, the thing that most people think about is crushing chest pain. It feels like an elephant sitting on my chest. I'm short of breath. You know, oftentimes it comes on very suddenly. People may have radiation down their left arm is a common thing. But a stroke is an artery that's blocked in the brain, and that causes a neurologic deficit. They usually don't hurt unless it's a hemorrhagic stroke. But these ischemic strokes where the blood clot blocks the artery, they cause you to be weak on one side, to lack sensation on one side, to lose your ability to talk, to lose your ability to see both sides, to be aware of what's going on. So they're very different, even though they're kind of fundamentally caused by a similar problem. So, okay.